This talk will cover the basics of regional anesthetic blocks, guiding principles and tips, and then go on to outline some of the easier blocks. And it's aimed at beginners in district hospital settings who want to learn some of these techniques. It's not possible to teach this subject in a short lecture, so I'm aiming to show you an approach that can be used to learn some of these techniques, but which will require your own effort to get better at them. So why bother blocking? The first is that you get excellent operating conditions. When the blocks work well, you can do the procedure with a high degree of patient comfort, and you don't usually require intravenous supplementation with other analgesics. You can do single operated procedures. So as a doctor that's isolated in a district setting, you can put the block in and focus your attention on the block, make sure it's working, and then you can carry on doing the procedure without having to worry about an anesthetized or sedated patient. If you are going to sedate or use an anesthetic, obviously you would then want two clinicians, one to watch the sedation or anesthesia and one to do the procedure. You can use much less. So especially for sick patients, if you've got a block in, then the sedation required is much less than you would have required if there wasn't that block in. And it's got many different uses in what are often difficult times. So if you've got a critically ill patient who needs a procedure done, the block has much less hemodynamic effect than sedation or anesthesia might. And often it's the way around difficult anesthetics is just to block the nerve to get the procedure done. So if I've got any advice about these, start on the easy blocks. Find the blocks that are easy to do. Learn the anatomy. The blocks are absolutely hinge on a thorough knowledge of the anatomy, and you're not expected to remember this from medical school days. You look it up and you see where the nerves run and you can block them. And there's very few areas of the body that can't be blocked if you know where the nerves go. And in the beginning, prioritize safety over success. Rather have a failed block, but the patient hasn't had any complications from that block, and prioritize that above all things. Success will come with doing multiple blocks, but I would really urge you to get good habits when you start doing these blocks. Now, this talk's not going to be about ultrasound guided blocks. In my opinion, once you get the hang of the ultrasound, they are easier, they are safer. You can block any nerve that you can find on the screen, but you need training. And if you don't have training and you start trying to do ultrasound blocks, you're going to make beginner errors like not knowing where the tip of your needle is, and you're going to end up sticking the needle into a vessel without you being aware of it. So in fact, if you're using an ultrasound and you haven't been trained, I think they can be more dangerous than blind techniques. Also, if you're going to use the ultrasound, you need the right probe. Most district hospitals have the curvilinear probe, but not all of them have the linear or the rectilinear probe, which you need in order to do nerve blocks. And these probes are not cheap. So getting that probe, if you have that probe, get trained in it, go and do InReach or go on a course, and then by all means use ultrasound as your preferred method. But the majority of doctors in these settings are doing blind approaches or potentially with a nerve stimulator. Now, when you're doing the blocks, I've stressed that you should put safety first. Some of the principles behind this: try and get a designated blocks area, maybe in your emergency department or in the theatre complex, where you always do the blocks. And then you can set up with the appropriate monitors, resus equipment, all the equipment that you need for the blocks. It's easier if you do them in one place every time. Get used to using a sterile technique. For most of the blocks, a good clean and sterile gloves is sufficient. You're not putting in a catheter such as an epidural catheter or an indwelling nerve catheter. If you were using catheters, you would need a full gown, mask and cap. But for these sorts of blocks, we think that sterile gloves are probably sufficient and a good clean of the area. Use the safest drug. So when you are unsure or you're just learning, lignocaine is a far safer drug than bupivacaine. Bupivacaine will give you a good duration of block, but if you do get side effects from these drugs, bupivacaine is the one that is very difficult to treat. Often an intractable ventricular fibrillation from toxicity or intraarterial injection, and really if you don't have intralipid to treat that, it's going to be difficult to treat. So when you're not sure, stick with lignocaine, provided it'll give you the duration that you need. Get the dose right. I'm going to go through how to calculate them and what the maximum doses are. Get the nerve right. It sounds like a stupid thing to say, but there have been so many instances where the wrong side has been blocked and you end up doing a brilliant nerve block in the wrong limb. So just make sure that you focus on those things. And then there are a few technique principles which I'm going to cover that are worth paying attention to. So in terms of blocking the wrong limb, this is an initiative that's been brought in the United Kingdom. It's called Stop Before You Block, and basically just before you put the needle in, you're supposed to stop and check the surgical site marking and the site inside of the block. And the reason that we end up blocking the wrong limb is because we get distracted, or because there's a long gap between the WHO checklist and the block, or because there's too much social activity in the room, or just because of human error. And these are called never events, and you really don't want to ever do this. They should never happen. So I mention it just so that you don't dismiss this. This can happen to anyone. Now, when you're working out drug doses, this is something that actually needs practice. Every single time I give local infiltration or I give a block, I do the calculations I'm about to show you. Now, the maximum drug doses for lignocaine are 3 milligrams per kilogram if there's no adrenaline in the solution, and 7 milligrams per kilogram if there is adrenaline. Bupivacaine, 2 milligrams per kilogram with or without adrenaline. So things to notice: the adrenaline changes the lignocaine dose that you can use, but not the bupivacaine dose. Secondly, you'll notice I'm showing you 2 milligrams per kilogram as the toxic dose. That is what it says in the package insert. But if you go online or you read various different resources about bupivacaine, you'll see that 2.5 milligrams per kilogram or 3 milligrams per kilogram is quoted. Those doses are not in line with the package insert, and I don't recommend using them because bupivacaine is the one that you really don't want to make a mistake with. So I stick pretty rigidly to 2 milligrams per kilogram, but I'm happy to go to that maximum because there are people making recommendations for higher doses out there. The doses are in milligrams per kilogram, so you need to work out what the maximum milligram dosage is. But the drugs come in percentages, and this confuses people. And the classic mistake is that people think a 1% solution has 1 milligram per mil. But in fact, to get milligrams per mil, you multiply that percentage by 10. So a 1% solution has 10 milligrams per mil. Now I'm going to show you some of those calculations just after this slide. Just a reminder that the side effects with these two drugs, lignocaine and bupivacaine, tend to be central nervous system and cardiovascular system. Those are the two broad categories of side effects you get. And there's a ratio for each of these drugs. For lignocaine, the central nervous system complications occur first, and you need 7 times the dose to get to the cardiovascular effects. Not the dose, but that's the ratio, 7:1. With bupivacaine, that ratio is much more narrow. So what it means is that when you start getting the central nervous system effects, you are very close to getting the cardiovascular system effects as well. And like I said, ventricular fibrillation is the one that you worry about. But if you see patients complaining of perioral numbness, or if they have a seizure, those complications need to be managed, but you need to watch out for the cardiac rhythm as well. And this is why we have monitors on these patients. So just to look at some of those doses, if you had a lignocaine 1% solution and you were trying to find out what you could give a 60 kilogram patient for a block, you would know that 1% means 10 milligrams per mil, so I multiplied by 10. and I'm allowed a maximum dose of 3 milligrams per kilogram. So if the maximum dose is 3 per kilogram, a 60 kilogram patient can have 3 times 60, which is 180 milligrams. I'm allowed 180 milligrams, and I've got 10 milligrams per mil, so I divide 180 by 10 to get 18 mils. So I can give 18 mils of 1% lignocaine. If I've got adrenaline in that, same amount of lignocaine in the solution, 10 milligrams per mil, but now I'm allowed 7 milligrams per kilogram, and 7 times 60 is 420 milligrams. 420 milligrams divided by 10 gives me 42 mils of 1% lignocaine with adrenaline. So that would be the maximum volume of that solution that I could give. And lastly, bupivacaine is a 0.5% solution. That means that 0.5 times 10 gives me 5 milligrams per mil. I'm allowed 2 milligrams per kilogram, so 2 times 60 gives me 120 milligrams. And if I divide that by 5, because that's what's in each mil, I get 24 mils. So I can give that 60 kilogram patient 24 mils of 0.5% bupivacaine. That's the basic calculation, and I advise you to do that as often as you can, because then it'll just settle. When you're doing these blocks, do not inject if there's pressure or there's increased pain as you're injecting. These are two fundamental rules. The worry is that you've stuck the needle into the nerve. Now you're trying to get into the sheath around the nerve, and when you inject slowly, that should never be under pressure. So whatever you're doing, if you're injecting and you feel like you're really having to strain against that plunger, stop. You're probably in the nerve or somewhere that you shouldn't be. And those are fundamental rules for any blocks. Now all of these blocks you can find on websites. The one I like is NYSORA.com, which stands for New York School of Regional Anesthesia. They've also got a really nice app, but the problem is that's a subscription, so then you have to pay for it. But if you go to their website, you can get all the blocks free, and they've got excellent descriptions in text and on videos. And if you search for the block and just write NYSORA next to it, you'll find that on YouTube. You can watch it. Some of the blocks I'm going to show you today come from this NYSORA site. There are other sites that you can check out. If you're going to use YouTube to watch a video of how to do this, Duke University does some nice ones. Just make sure that you're checking out the source. But I advise that when you decide to do a block, if you've got the time, look up the block and read about it. This is how you become good at blocks. And I regularly check how I'm doing my block with these sources. Now this is from NYSORA, so if you were to go to that website I've put up at the top, this is a wrist block. They show you where the nerve supplies and where the nerves run. So to do a wrist block, I'm only going to show you a little bit about the wrist block. The ankle block, you have to block 5 nerves, which means to me you just put a bleb around the ankle. But the wrist is 3 nerves, and often you won't be blocking all 3. You see the area in the hand that you need to block, and then you block them. The ulnar nerve the ulnar nerve and median nerves are the easier ones to block. The ulnar nerve, you stick the needle just under the tendon of the flexor carpi ulnaris muscle, close to its distal attachment, just above the styloid process of the ulnar. You can see the spot where you would put it in there, and that tendon is very easy to find. And the needle is advanced 5 to 10 millimeters, just past the tendon of the flexor carpi ulnaris, and you put 3 to 5 mils of local anesthetic solution, and that'll block the ulnar nerve, and you give that enough time to work. The median nerve, also very easy to block. You find that the nerve between the tendons of the palmaris longus and the flexor carpi radialis, and the flexor carpi radialis is, you can find it by doing what that picture with the green background is showing you, with the tension on the wrist, and it forms a little groove there where you stick your needle between the palmaris longus tendon and the flexor carpi radialis. And if you stick the needle through that gap, you can see where the needle is supposed to go from the diagram. You'll often feel a pop or a click as you go through the deep fascia, and that's where you should inject. But if you don't feel that, you can just keep going until you hit the bone, and at that point the needle must just be brought back about 2 to 3 millimeters, and you inject your local anesthetic. And again, 3 to 5 millimeters, not under pressure, and that'll block the median nerve. And those two nerves are quite easy to block, and usually when I block these, I have successful blocks. A little bit harder to block is the radial nerve because of the branches that come out. So the initial block is is as pictured. It's got a less predictable anatomic location and division into multiple smaller cutaneous branches. So you put 5 mils of local anesthetic just above the radial styloid while you advance the needle medially. And then you extend that infiltration laterally. But you've also got to block the dorsal sensory branch, which you can see in the second picture is a bleb of skin where the needle is, where it's illustrated there. And I tend to put 5 mils at each location, but in essence for the radial nerve you're doing a field block, so you let the volume of the local anesthetic work for you. And to be honest, when I'm doing wrist blocks, that's the one that I worry about, is my radial nerve blocks. Now I just want to make a point about digital blocks, probably the easiest block that we do, and one of the ones we learn first. Remember that you don't put adrenaline into the extremities. The old rhyme was fingers, nose, penis, toes. Those are the ones you don't give adrenaline to. Actually not a lot of evidence to show they cause harm, but best practice is to leave the adrenaline out, and you don't need much local anesthetic at these sites anyway, so you can quite easily get the volume you need with the lignocaine. And a digital block aims to block the nerves as they come up on either side of the finger that you're blocking. So here you'll see a diagram of that injection. You put three mils of lignocaine on either side of the finger. There are concerns from some orthopods that if you inject this under pressure, you can cause digital ischemia. So while this technique is still described and still found in the literature, some people think you should be getting your needle tip where this needle is pointing, either from the angle that's been shown on this picture or by directing the needle from the web space into that area, so that where the local anesthetic goes, there's not that higher pressure. So you're then doing a web block. Either technique is absolutely fine. You just need to get that local anesthetic on either side of the finger to block those nerves as they come into the finger. There is another approach called a volar approach, but I don't want to confuse you too much. If you look these up, they're all well described and successful techniques, and this is a block worth doing. Hematoma blocks. Some people swear by these blocks. The big concern is so the idea here is that you inject into the hematoma that is on a fresh fracture, in this case a Colles fracture, and you direct your needle into that hematoma. That's where you're going to inject, and then you manipulate that bone after injecting. The issue clearly is that you could potentially introduce infection into what is a closed fracture, and you convert that to an open fracture. So I would advise rigid attention to a sterile technique. Now there are multiple descriptions of this block in the orthopedic literature and in the anesthetic literature, and it's not felt that the risk is very high, but for me that's the thing that I'd be quite careful about. I would use sterile gloves. I would clean the area very well. So use sterile technique, inject into a fresh fracture site. It doesn't work if the fractures are very old. You're going to use about 6 to 8 mils of 2% plain lignocaine, and you confirm that you're in the right site by aspirating blood. So you are putting this lignocaine into what feels like a blood, but it's the hematoma that you're injecting into. And give it about 10 minutes. You need to give it enough time to anesthetize that area. And this is a good block. It's certainly something that will, you may still need to give some systemic analgesia, but you'll need much less, and often a patient will actually hold their own arm for you while you put the plaster of Paris on. I want to mention the Bier's block because it's a common block that's done in district hospitals. Again, you must read the full description of these blocks on the website rather than what is a very brief overview that I'm giving you. But to do this block you need a double cuff, and you may not necessarily have this. So the key is that you put full monitoring over these patients. and you insert a small IV line, usually on the wrist or on the hand, so distally, at least 10 centimeters from the tourniquet. You put this double cuff on and you clearly mark which is the proximal and which is the distal cuff. You elevate the arm and you use an Esmark bandage to exsanguinate the arm, and then you inflate the proximal cuff, so the one that's closer to the heart, the one that's closer to the shoulder, to a systolic blood pressure level plus 100 in adults or plus 50 in children. So that prevents both, that cuts off the arterial supply. You then inject lignocaine at that drip that you previously inserted. Generally use a 0.5% lignocaine solution, somewhere between 2 to 3 milligrams per kilogram of the body weight. You'll often see some blotchiness come. That doesn't mean it's an allergic reaction. It's a common reaction to the lignocaine. It takes about 10 to 20 minutes to work. And if your procedure goes on for too long, often the patients complain of pain at that proximal cuff. And what you do then is you inflate the distal cuff, which is now anesthetized. And once the distal cuff's up, then you can lower the proximal cuff. And that allows you to continue even if there's pain. And these blocks are really good for fracture manipulation or very short surgical procedures. They are thought to be more effective than the hematoma block. And then you need to leave that cuff on for at least 30 minutes, and then you can deflate it. Obviously the worry here is systemic toxicity from that amount of lignocaine that's gone directly into a vein. But if you keep that cuff up for 30 minutes, then it's not thought to be a problem. I want to mention brachial blocks really in closing. It's the last block I'm going to talk about. Now this is a more advanced block, and it's good for anything from shoulders down to hands. There are 4 basic approaches. The interscalene, which is considered an advanced block and is not something that you should be trying unless you've got significant anesthetic experience. The supraclavicular block, which many people do blind, but you need to do a lot of them before you get that technique right. They're the best ones to do with an ultrasound, as I'll show you shortly. The infraclavicular, which was a favorite of mine when I was learning, but needs a nerve stimulator to get it right. And the axillary, which is a good one to do blind, and that's the first block that I learned was an axillary block, and I'm going to briefly show you how you do that blind. Just to point out that if you are going to learn the ultrasound guided blocks, this is an excellent one to learn. The reason for that is that the nerves run very shallow where the probe is showing you there. They're accessible. The needle plane under that rectilinear probe is at almost 180 degrees, so it's very easy to see the needle, which is a big bonus. And then if you look at the ultrasound picture, there's a vessel there, and right next to the vessel are the nerves, and they form a sort of a triangle there where the brachial plexus sits. And when you're learning with an ultrasound, the ones that are next to a vascular landmark are always much easier. Now, I don't want people to try this block without someone to show them how to do it. There are rules with how we do ultrasound guided blocks. You really need to understand your machine, and you need to see the whole of that needle when you're moving it so that you can see exactly where your needle has gone. Having said that, this is the block that I will teach someone when they're a beginner with an ultrasound. It's a really nice block to learn, and it's very, very effective. This is how you do an axillary block. In this case, the practitioner is using a nerve stimulator, which is a good way to do a block. He or she's got his finger on the axillary artery. And there are 2 approaches that you can use here. The one's a para-arterial and the one's a trans-arterial approach. And you're trying to stick that needle into the sheath which the brachial plexus is running in. The para-arterial goes just next to the artery, and you just feel a pop as you go through that sheath, and then you inject up to 40 ml of bupivacaine. You usually have to dilute it down to something like a 0.25% mixture, but the volume really helps you get all the nerves in this area. The transarterial approach actually goes through the artery and injects on the other side. I wouldn't advise that, especially not if you're a beginner, but just be aware that if you're aiming to go just next to the artery and you hit it accidentally, you can still do a transarterial approach. I was a fan of the para-arterial approach, and in terms of the needle, we would use a little butterfly needle, and then it's got that connection that you can put onto a 20 ml syringe. You put the butterfly needle into the sheath. If you let go of the needle, you'll actually see it pulsing to show you that you're in the sheath. You aspirate to make sure you're not in the vessel, and then you slowly inject. And if you're in the right place, you won't see a bleb. You'll see that local just goes along the sheath, so you almost see no swelling as a result of a 40 ml injection. Very, very good block, and very useful. This is not a block you do if you've never done blocks before, and you have someone walk you through it. So this is the sort of thing you can learn when you're on InReach or when you've got a visiting anaesthetist with you, and you can get them to show you how to do this block. Very useful block, and having a brachial plexus block in your bag is always a good thing to know. Finally, I just want to make the point that if you do put in a successful block, before you send that patient to the ward or home, you need to check that the block has worn off. And some of these blocks, especially if you've used bupivacaine, can last 6 hours. And what will happen is the patient will have no sensation in that block and potentially injure the limb, either by lying on it or if they go home putting it on something hot, and they won't realize that they can't feel. And that while that block is still working, it's the hospital's responsibility to make sure that limb is being protected. So often it goes in a sling, or and you keep the patient until they've got sensation again. And it's one of those things you can just forget, and then you run into trouble. And that's all I'm going to cover with this talk. I think that really what I want to do is encourage the use of these blocks in a safe manner, but principally just to prime you as to what the techniques are. But these blocks need to be read up on. It's a continual learning process, and I think once you get into them, you'll just start adding new blocks just through your own reading and through online resources. Thank you very much.